And my task is to talk about Ehlers-Danlos syndromes and hypermobility spectrum disorders, and to give you an overview of the diagnosis and multidisciplinary management for these complex conditions. Thank you all for taking time out of your very busy schedules to be with us today. So we're going to start off by thinking about what are the Ehlers-Danlos syndromes. And these are a group of hereditary disorders, all of which involve the connective tissue. There are 14 different types, and these have a wide range of differing presentations. The underlying genes for 13 of these 14 types are known, but the gene for underlying the hypermobile type, the genes, we believe, underlying the hypermobile type of EDS are not yet known. The genes that we recognize involving the 13 known types affect structural proteins of the connective tissue and the enzymes involved in processing of these proteins. So we have 14 different conditions. We're lumping them under the category of Ehlers-Danlos syndromes. What do they have in common? Well, they all involve the connective tissue, and joint laxity is a feature for all of these disorders. The skin is involved in most of the types, with skin fragility, skin hyperextensibility, stretch marks, and easy bruising, predominant features of the skin in the Ehlers-Danlos syndromes. And many other organ systems are involved to varying degrees in the different types of EDS, and I will be going through the involvement of the different organ systems as we get further into the talk. So we're talking about hereditary disorders of connective tissue, so I think we should really do a little bit more exploration about what do we really mean by the term connective tissue. And in general, we use the words connective tissue to describe the materials that hold the body together. Connective tissue is found in every organ in the body, and examples of different types of connective tissue are tendons and ligaments, bone and cartilage, the dura, which is the material that surrounds the spinal cord and the brain, and there is subcutaneous connective tissue as well, sitting underneath the skin. When we look at connective tissue across the board, collagen is the most prominent protein in connective tissues in general. There are many different types of collagen, many different types of collagen. And there are also molecules that we call proteoglycans that require the addition of sugars to the protein background for them to be complete. So when we think about the proteoglycans, the collagens, the other molecules of the connective tissue, there are many genes encoding the proteins and the enzymes that process them that may cause the Ehlers-Danlos syndromes. And this is just an illustration of some of those types of connective tissue, which you can see here in the upper right-hand corner of this slide. There's fibrous connective tissue that makes up the tendon. There's loose connective tissue that sits under the skin. The blood is actually considered a connective tissue, as is adipose tissue or fat. Cartilage is another type of connective tissue, and bone is another type of connective tissue. Over here on this side of the slide, we see the triple helix, which forms what we call the fibrillar collagens. The fibrillar collagens are a subset of the collagen molecules that have a triple helical formation in the middle of the collagen molecule. And that triple helix is composed of 3 alpha chains. The alpha chains may be the same or they may be different. If they're the same, they're encoded by the same gene. If they're different, they're encoded by different genes. And what happens is the collagen triple helix is manufactured in the cell, and then it lines up in this way, according to this fibril schematic, into a collagen fibril, which looks like this on the electron microscope. So these are the fibrillar collagens, and over here on the left-hand side of this slide, we see some of the proteoglycans that play an important role in some of the rarer types of the Ehlers-Danlos syndromes. So here you see the core protein on the right-hand side of this illustration, and then the addition of different sugar moieties that make up the extensions, or what we call the chain polymerization, to create heparin sulfate or chondroitin sulfate or dermatan sulfate. And you can see there are different chains, different sugars that make up each of these glycosaminoglycan chain polymers. So that's a brief introduction to the molecules that make up our connective tissue. Now we'll think about how the Ehlers-Danlos syndromes are inherited, and this is very basic genetics, and many of you may be familiar with this material, so forgive me if I'm covering information that you already know. The most common forms of Ehlers-Danlos syndrome, which are the hypermobile type, the classical type, and the vascular type, as well as some of the rarer types, are inherited as autosomal dominant traits. And this means that an affected person has only a single copy of an altered gene, which may have been inherited from one of their parents, or the alteration may represent a new genetic change in the family. Most of the rarer types of Ehlers-Danlos syndrome are inherited in an autosomal recessive manner, which means that an affected person has inherited two copies of an altered gene, one from their father and one from their mother. And the parents are said to be carriers and are not affected. This is just a schematic illustration of autosomal dominant inheritance. On the left-hand side, you see a situation where there's an affected parent, in this case, the father, who carries one copy of a variant on one of his chromosomes. And his children have a 50-50 chance of inheriting that variant, or they may inherit the chromosome which does not carry the variant, in which case they will be unaffected. It's also possible for a child to have an autosomal dominant condition without having an affected parent if there is a new autosomal dominant variant that is in the DNA of the child, but not in the DNA of either parent. And this can happen if that variation is introduced in the process of creation of either the egg or the sperm that go into the creation of this offspring. Autosomal recessive inheritance is illustrated here. We have two parents, both of them are unaffected, but both of them carry a single copy of a variant on one of their chromosomes that encodes this alteration, which will eventually result in disease. So if the child inherits both variants or mutations from each parent, the child will be affected. If the child inherits one variant from the mother or one variant from the father, they will be a carrier. And if neither variant is inherited, the child is unaffected and not a carrier. So going back to the different types of Ehlers-Danlos syndrome and the types of inheritance for each of them, you can see that on this slide. The classical type is inherited as an autosomal dominant. And you'll see here the vascular type is inherited as an autosomal dominant and the hypermobile type as an autosomal dominant. There are some of the rarer types that are also autosomal dominant, the arthrochalasia type, periodontal type, and myopathic Ehlers-Danlos syndrome can be inherited as an autosomal dominant phenotype. And I really love this illustration from Joanna Amberger and Carol Bocchini and Ada Hamish from 2018, which shows the different types of Ehlers-Danlos syndromes as the petals of a flower with the type of Ehlers-Danlos syndrome listed on the outside of the flower and the genes that encode each of those types listed inside the petals. You will note here the hypermobile type is the only one for which the underlying genes are unknown. So how do we diagnose the Ehlers-Danlos syndromes? Well, in 2019, we used the criteria that were put forth in 2017 in the supplement to the American Journal of Medical Genetics, which was published in 2017. And this is available at the website for the Ehlers-Danlos Society. And you can see the URL here. We only have a short time to speak tonight, and so I'm going to focus on the 2017 criteria for diagnosing hypermobile Ehlers-Danlos syndrome. The criteria for diagnosing all of the other types are available in that American Journal of Medical Genetics, and that is freely available to all on the Ehlers-Danlos Society website. But now what I'd like to do is take just a few minutes and talk about the 2017 criteria for diagnosing hypermobile EDS, because this is in fact the most common form of Ehlers-Danlos syndrome. So you will also find at the Ehlers-Danlos Society a diagnostic checklist which was developed by Dr. Brad Tinkle, and I find this to be an extraordinarily useful document to work through when I'm looking to make a diagnosis of hypermobile Ehlers-Danlos syndrome. So there are three criteria that are examined to establish a diagnosis of hypermobile EDS, and the first criteria is that of generalized joint hypermobility. Now, for the 2017 criteria, a decision was made to differentiate among age groups for the cutoff for generalized joint hypermobility. We use something called the Beighton scale, which is a 9-point scale. And for people who are prepubertal children and adolescents, a score of greater than or equal to 6 is required. For men and women who are post-puberty but before age 50, we require a score of greater than or equal to 5. And for men and women over the age of 50, a score of greater than or equal to 4 is necessary in order to establish the condition of generalized joint hypermobility. And the Beighton score looks at 5 different maneuvers to examine the presence of hypermobility at these joints. So we look at extension at the metacarpal phalangeal joint. That's the joint where the finger joins up with the hand. On the 5th fingers of each hand, you can get 1 point for each of those. We look to see whether the thumb is able to touch the opposing forearm, 1 point for each of them if you're able to do that. We look to see whether the elbow extends more than 10 degrees beyond the straight line or more than 190 degrees on a goniometer, which is an instrument that actually measures angles in the joints. So, and I find it very helpful to actually use that goniometer because sometimes it's difficult to tell by eye. So if you have 2 elbows that both extend more than 190 degrees, we give you 2 additional points on the Beighton score. Then we look at the knees and see whether they hyperextend. And here again, the goniometer is extremely useful to assess whether or not there is hyperextension beyond 10 degrees from the straight line, which is the usual. 2 points for each of the knees if they do extend more than 10 degrees of hyperextension. And finally, there's 1 point if you're able to put your palms on the floor without bending the knees. So we go through these measurements and establish a Beighton score, look at the age of the person who's under consideration, and if they meet the cutoff, we say they have generalized joint hypermobility. Now, the committee that was looking at this in 2016 and published it in 2017 decided to use a 5-point questionnaire to kind of supplement the information available from the Beighton score. So the current criteria say that if 2 or more of these questions are answered in the affirmative, you may add 1 point to the Beighton score to establish a diagnosis of generalized joint hypermobility. And those questions are, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And finally, do you consider yourself to be double jointed? So again, if 2 or more of these questions are answered in the affirmative, we may add 1 point to the Beighton score to establish a diagnosis of generalized joint hypermobility according to the current criteria. And this slide illustrates those Beighton maneuvers again, just to review them. Putting your palms on the floor, opposing the thumb to the forearm, bending the little finger to 90 degrees from the back of the hand, bending the elbows backwards more than 190 degrees, bending the knee backwards more than 190 degrees. Now, criteria 2 requires 2 out of 3 features. The features are labeled feature A, feature B, and feature C, and we need either A and B, A and C, or B and C in order to say that criteria 2 is met. Feature A includes 12 different systemic manifestations involving the skin and other organs in the body. And if 5 or more of those are present, we deem feature A to be met. So these features are unusually soft or velvety skin, mild skin hyperextensibility, unexplained stretch marks, bilateral piezogenic papules of the heel. These are little bumps on the heel that are caused by pushing the fat out in between the connective tissue underneath the skin when you're standing on your heels. Recurrent or multiple abdominal hernias. Atrophic scarring. This is widened scarring involving at least 2 sites, but without the formation of the really, really terrible looking scars that we see in the classical Ehlers-Danlos syndrome. Pelvic floor, rectal, or uterine prolapse in children or men or women who do not have a history of obesity or other predisposing medical conditions. Dental crowding and a high or narrow palate. Long, thin fingers, as defined by the presence of a wrist sign or thumb sign on both hands. A ratio of the arm span to height of more than 1.05. So we measure the height, measure the arm span, and divide the arm span by the height. And if that number is greater than or equal to 1.05, this box gets checked. The last 2 items are echocardiographic criteria, the presence of mitral valve prolapse, according to strict echocardiographic criteria, and aortic root dilation with a Z-score of greater than 2. So that means more than 2 standard deviations above the mean for age and body size. Now, feature B of the second criteria is a positive family history where 1 or more of the first-degree relatives independently meets the current criteria for hypermobile EDS. And then feature C you have to have at least one of these as musculoskeletal pain in 2 or more limbs recurring daily for at least 3 months, chronic widespread pain for more than or equal to 3 months, or recurrent joint dislocations or frank joint instability in the absence of trauma. So if you have one of these, then you can say that feature C is met. And finally, criteria 3 is basically saying that we have done our due diligence and we are pretty sure that we've excluded all other possibilities in terms of making the diagnosis of hypermobile EDS. So we want to be sure that the person we're examining does not have really unusual skin fragility, which should prompt consideration of other types of Ehlers-Danlos syndrome. We want to exclude other heritable and acquired connective tissue disorders. And we want to exclude alternative diagnoses that may cause joint hypermobility because of either muscle hypotonia or connective tissue laxity. So in other words, we've done our due diligence. We've really thought about other possible diagnoses that might explain the phenotype of the person to whom we're speaking. This is an example of some of the types of skin involvement that would preclude a diagnosis of hypermobile Ehlers-Danlos syndrome. On the left, you have the very typical scarring that we see in the classical type of Ehlers-Danlos syndrome. And on the right here is a gentleman who has the extraordinarily stretchy skin, which is also typical of the classical type of Ehlers-Danlos syndrome. Now, I would like to mention at this point this idea of a spectrum of joint hypermobility, which was a really new idea that came out of the deliberations for the 2017 publication. Dr. Marco Castori and the committee that was looking at hypermobile Ehlers-Danlos syndrome in 2016 came up with this idea that there is a spectrum of joint hypermobility that runs from asymptomatic generalized joint hypermobility all the way through to hypermobile Ehlers-Danlos syndrome. And they posed an idea that you might have, there are 3 different types of joint hypermobility. You might have generalized joint hypermobility where you actually meet the criteria according to the Beighton score. You might have peripheral joint hypermobility, where the joint hypermobility is limited to the joints in the hands and the feet. Or there might be limited joint hypermobility, where the joint hypermobility is just limited to single joints or body parts and is not generalized or even peripheral, but just found in one or a few joints. And that, or any of those, generalized joint hypermobility, peripheral joint hypermobility, or limited joint hypermobility, may be asymptomatic. So that's at the extreme mild end of the spectrum of joint hypermobility. Now, you may have a hypermobility spectrum disorder in which people are symptomatic. So these next 3 items are the hypermobility spectrum disorder, symptomatic people with either generalized, peripheral, or limited joint hypermobility. But we recognize that people with these hypermobility spectrum disorders may very well be suffering with many of the same comorbid conditions and be limited by their condition to the same degree as people with the hypermobile type of Ehlers-Danlos syndrome. This was just a way of acknowledging that there is a group of people who are symptomatic and have some degree of hypermobility, but do not meet the criteria, the rather strict criteria that were established for hypermobile Ehlers-Danlos syndrome in 2017. I'd like to point out this one other diagnostic category, which is that of historical hypermobility spectrum disorder. And these are people who had joint hypermobility in the past, but no longer have it at the time of their evaluation or examination. So they may report that they had joint hypermobility when they were younger, as teenagers or young children, but they do not have it at the age in which they're presenting to the physician. So their Beighton score will be negative, but they may suffer from many of the comorbid conditions and the situations that we see in these other diagnostic categories just as well. So, as I'm sure most of you on this call are aware, the Ehlers-Danlos syndromes and hypermobility spectrum disorders do not just represent the bendy joints that you see on these photographs from the national competition of the gymnastics that was held in Nashville very recently. And the former chair of our Medical and Scientific Advisory Board, Dr. Heidi Collins, coined this phrase, if you can't connect the issues, think connective tissues. And this reflects the idea that the symptoms presenting in hypermobile Ehlers-Danlos syndrome and the hypermobility spectrum disorders may affect virtually every organ system in the body. In the cardiovascular system involving the heart and the blood vessels, we may see orthostatic intolerance. This means that when a person goes from lying down to sitting up or standing, they develop a rapid heartbeat or their blood pressure may drop and the patient may become symptomatic as a result of the rapid heartbeat or the low blood pressure. So they may become dizzy, woozy, may even have shortness of breath, or chest pain as a result of that. Mitral valve prolapse is another feature in the heart, and the aortic root dilatation is one of the current criteria for hypermobile EDS. And venous insufficiency is a phenomenon where the veins do not adequately return the blood from the periphery to the central part of the body, back to the heart, and to receive oxygenation in the lungs. So the venous insufficiency can play a really important role in orthostatic intolerance. Now, when we think about evaluating the cardiovascular system in people in whom a diagnosis of hypermobile Ehlers-Danlos syndrome, or really any type of Ehlers-Danlos syndrome and hypermobility spectrum disorder has been made, we will typically do an echocardiogram to look for mitral valve prolapse or aortic root dilatation. If people are having palpitations, extra beats, or skip beats in their heart, we would consider something called a Holter monitor, which monitors the heart rhythm over a period of time, 24 hours or even a week sometimes. And some people will do a tilt table test to establish a formal diagnosis of postural orthostatic tachycardia syndrome. And these are just some of the treatment strategies that we think about for treatment of the cardiovascular involvement. We want to ensure that people have adequate salt and fluid intake if they are experiencing orthostatic intolerance. Sometimes compression hose can be helpful to help improve the venous return from the periphery. And most recently, the availability of compression garments from uh, manufacturers that make things like sportswear. So compression bike shorts are helpful in this regard, and even the compression undergarments from a company like Spanx or similar manufacturers can help with the venous return. We use salt supplements, electrolyte supplements, and two of the ones that I've been recommending include New One active hydration tablets or the Salt Stick capsules. There are many others that are out there, including liquid IV and banana bag supplements. Rarely we may encounter an arrhythmia that requires an intervention of a cardiovascular intervention, but all of these things have to be done under the supervision of a physician. So I would say the first step is to find a doctor who's familiar with these issues and is able to help guide you through the management. And one last item is that the mast cell activation may exacerbate symptoms of dysautonomia. So it's important to look for the signs and symptoms of mast cell activation and treat them appropriately. And I will talk a little bit more about mast cell activation a little later in the presentation. Now, there is a great deal of neurologic involvement in many of the patients who have the Ehlers-Danlos syndromes. Headaches are of many different types. I've heard Dr. Fraser Henderson talk on this subject, and he has listed 13 different types of headaches in people with Ehlers-Danlos syndrome. Just to mention a few of these, they may be due to either high or low pressure in the cerebrospinal fluid. Headaches may be caused by muscle spasm. They may be caused by migraine, which is a vascular cause of headache, and they may be neurogenic, in other words, caused by compression of the nerves that go to the muscles in the scalp. There is a phenomenon called cervical medullary syndrome, which is caused by something called Chiari malformation or craniocervical or cervical instability. And I'll talk a little bit more about that on the next slide. Autonomic dysfunction is a manifestation of neurologic involvement. Patients may have neuropathic pain because of nerve compression due to unstable joints. There's a phenomenon called small fiber neuropathy, which is seen in some people. This can be a result of an autoimmune phenomenon. Occult tethered cord is a neurologic complication, and cerebral venous insufficiency has also been reported in some of these patients. So the neurologic evaluation includes a full neurologic exam. The cranial nerves should be tested. We should be looking at reflexes in all the extremities. We want to look for clonus, which is a form of extreme reflex. We test for proprioception. In other words, are people able to tell where their joints are in space, when their limbs are in space? So really comprehensive neurologic examination. If there are signs and symptoms suggestive of cervical medullary syndrome, and I tell you what those are in a minute, we do an MRI of the brain and neck in an upright position with flexion and extension views of the neck. If a tethered cord is suspected, we might do urodynamic studies to look and see whether there's evidence that the nerves going to the bladder are being pinched by a tethered cord. We do a test called an MRV, which is a magnetic resonance venogram, if increased intracranial pressure is suspected, and that there are other kinds of tests that might be done if that increased intracranial pressure is suspected also, and a skin biopsy for small fiber neuropathy. So I would emphasize again that this is really in the purview. You should be in the hands of a neurologist who's familiar with all of these complications to really think about what the differential diagnosis is and to do the necessary but not excessive testing in order to get to a correct diagnosis. So the concept of the cervical medullary syndrome was discussed in a consensus statement that was published by the Chiari and Syringomyelia Foundation as a result of their multidisciplinary colloquium for craniocervical hypermobility in 2013. And this is just a sort of a snapshot, a brief overview of what the symptoms of cervical medullary syndrome are. They include headache and pain either just underneath the occiput, right at the base of the skull, or in the neck. There's a group of symptoms that are called bulbar symptoms because they're caused by compression of the cranial nerves, and they include altered vision, double vision, kind of abnormal movement of the eyes called nystagmus, problems with hearing. Should add tinnitus to that, ringing in the ears, dizziness or problems with balance or vertigo, difficulty with choking or with speaking or with swallowing, problems with the autonomic nervous system, the postural orthostatic tachycardia syndrome that we discussed earlier, fainting or a feeling like you're going to faint, and disordered sleep architecture and sleep apnea. All of these are symptoms we call bulbar symptoms. And then also there may be symptoms of myelopathy, meaning that the nerves that go to the muscles are being pinched. So there's weakness, clumsiness, spasticity, altered sensation, kind of paresthesias or tingly sensation or abnormal sensations in the skin, changes in gait, and urinary urgency and frequency. This is just a brief overview of a really quite complex subject. So neurologic intervention for these things, if we do an MRI and see a Chiari or what we call a low clivoaxial angle or basilar impressions, means the basilar impression means that the brain is actually being impinged at the base of the spine. It's definitely time to call neurosurgery. Similarly, if the urodynamic studies are suggestive of a neurogenic bladder, we want to refer to neurosurgery for assessment of a possible tethered cord. Sometimes the patients will say, my head just feels too heavy for my neck. I just can't support my head. I have a bobblehead. And for those patients, sometimes it's really helpful to use a cervical collar. And if a soft cervical collar doesn't work, the Aspen Vista collar is an excellent harder collar, more rigid collar that actually supports the craniocervical junction, that place where the head joins onto the neck, and the neck. Sometimes patients don't tolerate that Aspen Vista collar, and the Bauerfeind Cervilock collar is a soft cervical collar that may be better tolerated in some circumstances. Now, if people have increased intracranial pressure, we use a medication called Diamox, which actually decreases the volume of the cerebrospinal fluid in the head. And the problem with Diamox is that it's not tolerated by people with sulfa allergies. And also, it does cause you to lose bicarbonate, which is a very important molecule for the maintenance of the acid-base balance in the body. So we need to monitor blood values for bicarbonate and also for potassium in people who are taking Diamox. Again, this is a medication, needs to be prescribed by a physician, and it needs to be done in the setting of somebody who's really quite knowledgeable about these issues. There is a phenomenon called central pain sensitization. So chronic pain is very common in people with the Ehlers-Danlos syndromes, and this central pain sensitization may be responsive to vagal nerve stimulation or to cognitive behavioral therapy. And finally, it's really important to remember that the temporomandibular joint is very closely connected to the head and the neck. Well, TMJ is part of the head, but it's connected to the neck as well. So if the temporomandibular joint is not functioning properly, it can throw the neck out of alignment and contribute to a lot of symptoms that are attributed to the neck. So it's important to evaluate the TMJ as part of the evaluation of a person who has head and neck pain. Moving on to the gastrointestinal system, we see multiple symptoms in this organ system as well. People may have esophageal reflux, irritable bowel syndrome, bloating. There's a phenomenon called sphincter of Oddi dysfunction. The sphincter of Oddi plays an important role in regulation of the um, digestive juices that come from the pancreas and the liver into the GI tract. Patients may report abdominal pain, diarrhea, constipation. They may have difficulty controlling their stool. They may have food intolerance. They may have hernias. So pretty much any symptom that you might think of in the GI system can be seen in the Ehlers-Danlos syndromes. And we want to conduct a very comprehensive evaluation to look into the cause of these symptoms. And I've just listed a few of these here, but here again, you want to be working with a gastroenterologist who understands about Ehlers-Danlos syndrome, knows the various complications that may occur, and will conduct a very thorough but directed evaluation for the specific symptoms that a particular person is undergoing. So if the motility studies demonstrate that there is problem with motility either in the stomach or the lower bowel, there are a number of drugs that help move things along in the GI tract. So those prokinetic drugs may be helpful. If a person has irritable bowel syndrome and it's mostly diarrhea and they're having abdominal pain, gas, and bloating, we consider a trial of the mast cell protocol in those conditions. And I'll talk a little bit more about that in a few slides. There's a drug called Mestinon that has been helpful in some cases for poor motility. And if the person is taking opioid medications for pain, those opiates can really cause severe constipation. And there is a bowel-specific opiate antagonist. Now, there are several that have become on the market in the last couple of years, so that they limit the effects of the opiates in the bowel, but do not limit the effects in pain relief. So people can get their GI motility back without sacrificing the pain advantages, the solution that the opiates provide for pain management. We want to ensure that people have adequate nutrition. Nutrition is really key for optimal health. We know this. And if people are on proton pump inhibitors, that can reduce the absorption of certain vitamins and nutrients. So we try to encourage people to make sure they get their vitamins prior to their first dose of proton pumps if it's necessary to reduce the gastric acid to improve symptoms. Now, in the genitourinary system, people may report urinary urgency. They may have frequency or burning on urination, difficulty initiating the urinary stream. Some people say they have a lot of trouble emptying the bladder completely. They'll pee and then they feel like they still have to pee. They may have urinary dribbling or frank incontinence. They may report frequent urinary tract infections, but some of these may be culture negative, so they feel like they have a urinary tract infection, but you don't actually grow any bacteria when you look at the cultures. Women, in particular, may present with pelvic floor dysfunction and pelvic pain. So in conducting a urologic evaluation, we want to do a thorough exam as for all of these things. Check for tenderness over the symphysis pubis and the kidneys. We want to look for evidence of a neurogenic bladder. Excuse me. If, if we're suspicious of the presence of a tethered cord, and there's a series of nerve conduction studies involving the pudendal nerve that may also point to compression of the cauda equina, which is what we see in the tethered cord. And referral to urogynecology. These are specialists who understand both the gynecologic system and the kidneys and the bladder and the pelvic floor for assessment of pelvic floor muscles and possible assessment for mast cell activation in the bladder. Pelvic PT may be very helpful for pelvic floor dysfunction. Here again, if interstitial cystitis is diagnosed or suspected, this can be a mast cell phenomenon, and so the mast cell protocol may be helpful in this case as well. And if the urodynamic studies are done and they do indicate a neurogenic bladder, and the tethered cord questionnaire and the physical exam are suggestive of a tethered cord, referral to neurosurgery is indicated. And here again, you want to try to find a neurosurgeon who's well aware of these symptoms and the kind of approaches that are taken in management. Okay, moving on to allergy, immunology, and hematology. You may recognize here that we're basically discussing the textbook of medicine. Virtually every organ system in the body can be involved in these disorders, and that's what makes it so very challenging, not only to live with the condition, but also to provide comprehensive care for patients who have them. In the allergy, immunology, hematology arena, patients may present with a history of hives, a history of rashes and flushing. They may tell you they just itch all the time. There may be a history of frequent infections, severe allergies, autoimmune disorders, and a history of blood clots. Or on the other side, people may tell you, I bleed really easily and I don't clot well, and my blood just keeps coming without clotting. So that can also be a symptom. So when we're thinking about the evaluation for hematology, allergy, and immunology, we want to note the presence of flushing. Often we see this around the neck and the chest. There may be redness on the skin after the blood pressure is taken. And there's also a phenomenon that we call dermatographia, which is the ability to write on the skin with the pressure of a fingernail. So a line will be left behind after you drag a fingernail across the skin. And if a history of frequent infections is elicited, I always consider an immunological workup to assess the level of antibodies in the population of T and B cells, because these are the actors that are responsible for fighting off infections in the body. If people say that they have a tendency to bleed or to clot unusually, a full evaluation and anticoagulation coagulation evaluation is indicated, and if there is a predisposition to clotting, anticoagulation may be in order. There's a very interesting book called The Walls Protocol by Dr. Terry Walls, and she talks about how she has really been successful in treating many people with autoimmune conditions by the use of a nutritional intervention. This is very, very interesting. Sometimes we need IVIG or plasmapheresis in the face of serious autoimmune conditions, including some of the autoimmune encephalopathies or immune deficiencies with low immunoglobulin levels. And we also want to make sure that people have adequate levels of vitamin D. A target between 40 and 50 nanograms per deciliter is probably optimal. Often the normal ranges may go as low as 20 in some laboratories, and 20 is really probably not sufficient for many people. And people who have a higher gastric pH because they're on proton pump inhibitors or H2 blockers, they may need increased supplementation to achieve therapeutic levels. So I've mentioned the mast cell protocol several times, and you've heard throughout the presentation that the mast cells may be active in many, many different organ systems. They may play a role in aggravating the dysautonomia, they may play a role in aggravating gastrointestinal complications, and they may play a role in the GU system manifesting as interstitial cystitis, as well as they may be seen and present with symptoms in the skin with itching, hives, rash, flushing, etc. So virtually every organ system may be involved with the mast cells. And if we have a high suspicion of mast cell activation, we use a kind of a three-pronged approach. And here again, you don't want to do this at home. You want this in consultation with a physician who's familiar with mast cell activation and who will be sure that no other diagnosis is explaining the symptoms that you are experiencing. But if we have a high suspicion for mast cell activation, we use drugs that block the effects of histamine, that stabilize the mast cells, and we look at a diet that will minimize the effects of histamine in the body. So low histamine foods for 3 weeks, and then gradually adding in one food each day that's either labeled a 2 or a 3, and tracking your symptoms of pain, itching, rash, etc. There's a book called Is Food Making You Sick by James Gibb that talks a lot about these issues, and also the website healinghistamine.com has a lot of good information. Now, finally, in the musculoskeletal system, we look at muscle pain and spasm as one of the most challenging aspects of the hypermobile EDS phenotype, but also for other types of Ehlers-Danlos syndrome, and certainly also for the hypermobility spectrum disorders. In all of these conditions that are manifesting joint hypermobility, the muscles are literally trying to hold the body together, and they are going into spasm in the process and causing pain. So the musculoskeletal involvement includes the joint laxity and instability, subluxations and dislocations, chronic musculoskeletal pain, frequent sprains. Our examination for the musculoskeletal system includes the Beighton score, looking at neck mobility, the shoulders, the hips, the small joints in the hands. We look for the presence of flat feet or pes planus, and the presence of ankle pronation. And also the thumb and wrist signs, which are part of the diagnostic criteria now for the hypermobile type of Ehlers-Danlos syndrome. These are some of the strategies that are, they're useful for treatment of musculoskeletal symptoms in people with the Ehlers-Danlos syndromes and hypermobility spectrum disorders. We stabilize unstable joints on an as-needed basis. Sometimes people are worried that the braces will cause weakness, but if you just use the braces when you need to use the joint and take them off when you don't need to use the joint, then those braces will not cause weakness. We use physical therapy for muscle relaxation, and then muscle exercises to tone and strengthen. Myofascial trigger point release, which may include dry needling, electrical stimulation using a TENS machine or other devices that can help to get the muscles to relax. Epsom salts are a very useful modality. They are magnesium salts and they help with muscle relaxation. You can use them in a foot bath or in a bath. PT for toning and strengthening. Aquatic physical therapy is very helpful. I prescribe a compound analgesic cream, which is a combination of these 6 ingredients that are listed here. We use muscle relaxants if necessary. And Botox can be helpful, but you want to be careful, because if you apply Botox to the neck muscles, you might wind up unable to hold your head up for 3 months, and that is not a desirable outcome. Finally, coping is a difficult thing when people have chronic illness and they're not feeling well. So I really think it's important for people to have coping strategies, including cognitive behavioral therapy. Mindfulness-based stress reduction can be very helpful, and this Palouse Mindfulness website provides a comprehensive introduction to mindfulness-based stress reduction. It's completely free. Biofeedback and neural feedback are also very helpful for coping strategies. And utilize your patient support groups, and particularly the Ehlers-Danlos Society, this Ehlers-Danlos awareness group, and the Facebook groups that are out there can be very helpful for providing support. Finally, exercise is a really important component of the coping mechanism. It can help with pain management, with sleep, with digestion and mood. And I recommend to people 30 to 40 minutes daily of low impact exercise most days of the week. And this can include walking, biking, the elliptical machine, rowing machine, water exercise. But it's really important to get the exercise that helps the body make the endorphins, which are our own pain medication, and very, very important for pain management. So it takes a village to manage the many, many organ system involvement that we see in the Ehlers-Danlos syndromes and hypermobility spectrum disorders, and multidisciplinary evaluation and management is essential. So that concludes my presentation, and I really thank you for your attention.